So hello friends, welcome to my new video. So today in this video, I'm going to discuss with you all about a very important topic that we all should know as an optometrist, and it's also very important in our day-to-day OPD practice, that is to know about accommodative spasm. So from this term accommodative spasm, we can understand that accommodation ability is not able to work properly, so that we are going to discuss. So from this video, from this picture, you can see that here in this section it is shown that the lens is in unaccommodated state, and here lens is accommodated state. So in my previous video on accommodation, I told you that we do accommodation to see a near object clearly, okay, but in due to some conditions, our eye remain in accommodated state and not able to change the accommodation and get relaxed for distance. Okay, so accommodative spasm is that condition where there is a constant form of accommodation is seen, and here lens is unable to relax and stuck in that accommodated state for a prolonged period of time. That is called as accommodative spasm. Okay, so due to this prolonged time of accommodated state of the lens, it leads to more positive power inducement in the lens. Because when the lens is in unaccommodated state, we know the lens is having dioptrical value of plus 18 diopter to plus 20 diopter. But when lens do accommodation, then its refractive power also increase. So if this accommodation still persists for distant object also, then due to this over plus or over positive power buildup in the lens, it will lead to produce of myopia that we are going to discuss also. Okay, so what are the causes of accommodation? So there is different causes of accommodation, but in this video we will focus on two main causes. First is prolonged near work, and second is visual hygiene. So nowadays, we see mostly children are engaging themselves in digital devices like mobile phone, laptop. They are engaged in online classes, or they are more engaged in playing games or watching those YouTube entertainment videos. So that what is happening is that they are constantly using their accommodation to see their mobile screen. So it is leading to constant activation of accommodation, and they are not looking at far object, they are constantly looking at the near object. That is, they are holding their mobile phone at 20 centimeter distance and they are constantly watching it. We all know that a normal human being should have screen time of 3 hours in a day, but normally what we see in our day-to-day life that normally the children are mostly having screen time of 10 hours, 12 hours in a day. So it's very bad, and due to this over activation of accommodation for a prolonged period of time, then the ciliary muscles actually goes to a fatigue state, because there is no change of the focus, then constantly accommodation is activated for a prolonged period of time for several days or month. So if it is continued, then it is leading to this accommodative spasm. That means the lens get stuck in that accommodative state for near. So when the patient is looking at a distant object, then lens is not able to change its focus from near to distance, because the muscles are not actually working properly, so that the accommodation still work for distant also, and it is leading to deviation of the eye, because we know that AC from AC by A ratio, with each diopter of accommodation there is 4 prism diopter of convergence is there. So if the person is actually inducing accommodation for distance, then when the person is looking for a distant object, then also convergence will happen. So in these accommodative spasm cases, mostly we see esophoria or inward deviation. Okay. Another thing is the visual hygiene. So this visual hygiene means that suppose you are doing study in a low illuminated room. That means the room is not properly illuminated. So it is leading to induce of accommodation. Unwanted accommodation is generated, and this unwanted accommodation will lead to accommodative spasm. If you do study in that poor illuminated room for a prolonged period of time, then it also can lead to accommodative spasm. So what are those symptoms? Symptoms include blurry vision, headache, double vision, high myopia, or inward deviation of eye. So here, why I include high myopia? Because I told earlier that in accommodative spasm, lens remain in accommodative state for distant object also, because lens is not able to change the lens is not able to relax for distant object. So the lens remain in accommodative state. So due to this thing, it is leading to unwanted myopia formation. That is actually not true myopia, that is a pseudo myopia. And this leads to, you will get mostly -7 or -8 diopter of myopia. Okay, so this is why high myopia is there. And inward deviation of eye means the more amount activation of accommodation, the more will be the convergence and also meiosis of the pupil that you will also see. Okay. Now are the clinical features. So clinical features are sudden onset of blurring of vision with diplopia, sign of increased myopia, myotic pupil also can be seen, and isodeviation of the eye. Okay. So how to diagnose? There is some diagnostic criteria like visual acuity is not proportionate to the refractive error that you are getting in your retinoscopy. Okay, suppose you are getting retinoscopy value of -7 or -8 diopter, and the visual acuity is not proportionate with that retinoscopy power, and it will be lesser, like 2200 or 2125, something like that. Means visual acuity not correlating with the retinoscopy reflex. Okay, it can be a thing. Another thing is that you will get vacillating retinoscopy reflex, and there is a difference. That means the difference of dry and cyclorefraction. So what is vacillating retinoscopy reflex? So vacillating retinoscopy reflex mean the changing of the retinoscopy glow from dull to bright, and changing of refractive error from high to low. I'm telling about the high myopia to low hypermetropia. That means there is a hyperopic shift of refractive error is there. Suppose you are doing dry retinoscopy, you will get high myopia. And after you put the cycloplegic drop, then there is hyperopic shift of the refractive error. So it is indicating that there is presence of accommodative spasm. Another thing is that disappearance of isodeviation after cycloplegic installation. Why? Because in accommodative spasm, lens remain in accommodative state for a distant also. For distance and near, convergence is also creating. But when you are putting cycloplegic drops, then accommodation get relaxed, so that there is no convergence, because if there is no accommodation, then how convergence will appear? So convergence also get normalized. Okay. Another thing is the varying pupil size during retinoscopy. So you will see this vacillating reflex in retinoscopy when you do retinoscopy and see the glow by taking proper time. So if you are getting these things, then you need to take a proper time and do the retinoscopy. Okay, because normally in our day-to-day OPD practice, what we are doing, we are taking very less time in retinoscopy, because just we are seeing the glow and putting the working distance, and after that we just neutralize the patient. But in case of this special type of cases, we need to take proper time and then check the patient. Okay. Management. First of all, give the patient full correction to the patient after cycloplegic refraction. Okay. And reassess the visual acuity after 2 to 3 days during PMT. Okay. So we will not call this at PMT, we can call it PCT, post cycloplegic test. Okay. And here I use the term SNR, that means spasm of near reflex. That is another name of accommodative spasm. Okay. So the spasm of near reflex or SNR considered to be stable if visual acuity is stable, retinoscopy is also stable, and patient is symptom free. And if these things are, you are seeing that visual acuity is stable, retinoscopy is stable, and patient is symptom free, then give the patient spectacles and also advise vision exercises like pencil push up, Brock string, all those things. Okay, so mostly in accommodative spasm cases, these things work. But suppose this thing is not working. Okay, even in your post cycloplegic test, you are observing that the visual acuity is not improved, or there is vacillating reflex, or all those things are there. Then what you will do? So if this condition still persists, then modified optical fogging is done. Okay, and after that, in most cases, after doing the modified Boris delayed subjective refraction, there is improvement of visual acuity from 2020 to 2025. So how to do this modified Boris delayed testing? So here, what you need to do is that you got the subjective value after cycloplegic refraction, and you also need to measure the negative relative accommodation. Okay, so this negative relative accommodation is that the highest plus lens or plus power that the person can bear with. That means with minimum effort of accommodation. That means to relax the accommodation, we are relaxing the patient accommodation, we are making the patient myopic, and we are going to see that at how much amount he can relax his accommodation to see that object clearly. Okay, so that is negative relative accommodation. So here, to measure it, how you will do it, you need to show the patient a near target and then binocularly put plus power lenses at plus 0.25 steps until the patient report first sustained blur of that near target. When the patient reports that the object is appearing blur after putting the after putting the plus lenses, then you will stop and see what is the amount of that glass power. So normally NRA value, the normal range is plus 2.50 or less. If it is more, then it is abnormal value. So we are taking normal values. Okay, so in the subjective refraction after cycloplegic, you got a value that is refractive error, refractive power, and you will need to add that refractive error with the NRA value plus 2.50. Okay, and you need to uh, give the patient a near object to read. So suppose it's a newspaper or a comic book. Okay, and put that NRA value plus subjective refraction value in front of the patient, both eye binocularly, and make the patient to read it, and allow the patient to read that near things for at least 30 minutes, and after that give the patient to read the distant largest optotype, and then instruct the patient to read from upward to downward and then slowly defog the patient, and at that amount of lens power, with that the patient is reading 20/20 or those 20/25 highestly, then record it and give the refractive uh, give that power to the patient, and that is the final power that you got in modified body delayed subjective refraction. So mostly we see that after giving that power by following the body delayed subjective refraction, we actually don't need cycloplegic refraction. But suppose even after doing this modified body delayed subjective refraction, the SNR still persists, then what we will do? We will give the patient atropine eye drop and instruct the patient to use this atropine eye drop twice a day for 3 days, and then perform refraction on fourth day. The patient vision is rechecked after 2 weeks following the same protocol, and then give instruct the patient to come in a follow-up visit at 3 months of interval. And during this atropine sulfate procedure, give near vision spectacle of plus 3 diopter. Okay, and even after this thing, if the condition not improve, then with atropine you are going to perform again modified body delayed subjective test and again give the patient time to follow up. So after doing this, it's definite that the patient's accommodative spasm will get relaxed and he will get 20/20 visual acuity. Okay, so that's all friends, thanks for watching, and please don't forget to like my video and subscribe to my channel.